Scott County, providing safe, healthy, and livable communities.
Health Mobile Crisis and the Residential Intensive Treatment Services. Welcome to the panel, and Chris Harder will get us started.
Thank you, Madam Chair. Good morning, Commissioners. This is kind of an exciting opportunity to talk about this intersection between many things we've been talking about over the last few months. You're going to hear today examples of innovation and some risk-taking and some creative thinking. You're also going to hear about collaboration with public-private organizations. You're going to hear about collaboration within the county. And the work that was done came from our existing strategic plan on decriminalizing mental health, but I also think it sets a great bridge for the strategic plan that we're moving into and how we continue to provide services in a way that's this creative. So I'm going to ask the people who are on the panel to introduce themselves, then ask our presenters to introduce yourselves. Danielle's going to say a couple opening comments, and then we'll get started.
All right, I'm Scott House, the Director of Emergency Management and 911 Communications for the Sheriff's Office.
Cindy Geis, Community Services Director.
Good morning, Jen Schwartz, Health and Human Services Admin Director.
Lori Reller, Adult Mental Health.
Steve Brown, Children's Mental Health.
Beth Sheet, Service Director at Guild Incorporated.
Jody Kieser-Kisting, Assistant County Attorney.
Buchanan, County Sheriff.
Terry Raditz, Director of the Mental Health Center.
Good morning, I'm Danielle Fox. I'm the Adult Social Services Manager here at Scott County. Thank you for having us. Do you want to introduce yourself?
Sorry, I'm Karen Jensen. I'm the supervise the Canvas Health Scott County Mobile Mental Health Crisis Team.
So as you can see, mental health crisis, we have a lot of crises, so people might be popping in and out as things go.
Yes, sorry for my lateness.
But we're happy to be here today. We had presented a Scott County Delivers presentation about 18 months ago, which provided an update on, as Chris said, some of the board strategy work. I think 18 months ago we were in a good spot, and we were excited about some new things that were happening and some developments. But I think being here today, I think we can really just appreciate the incredible work that's been done, the commitment that Scott County has had to mental health, and the partnerships that we've been able to bring to this table to make some really big things happen in our community. Just a couple of things to note. The Mobile Mental Health Crisis Team, we've seen many more people served in the community. We've seen many more people who have been served outside of the hospital in their homes. We've seen some incredible new partnerships with law enforcement and other community partners. We also, I just saw pictures yesterday of structures going up for the new intensive residential treatment services, or the IRTS and crisis facility that Guild will be operating, which is really just incredible. I think we've been talking about that project for over 5 years, so to see those walls start going up is just incredible. We recently got information from the Department of Human Services just yesterday that identified our use of intensive residential treatment service beds. In 2018, our community members used 1,100 bed days, and in 2019 that's gone up to 1,900. So that's a pretty significant increase in just 1 year, and to think that right now all those individuals are traveling long distances or having to wait for services for a bed to be available is really, really great and really exciting. We also received grant funding from the Department of Human Services to have a half-time outreach worker for individuals who are experiencing homelessness and mental illness. So that just launched in July of this year. So lots of new, exciting opportunities. I think we've also identified some bottlenecks as we've grown services in some areas. I think we're seeing needs in others that have popped up. But I think we are lucky to have this great team here today to help us chart through those next challenges.
Thank you very much. All right, does somebody on the panel want to start the questions?
I can start.
Okay, thanks, Jen.
On page 9, the repeat pre-petition screenings. I'm curious about there's been a big drop in those, and so I'm curious what your thoughts are on how you've been able to effectively change that, but also maybe start with what that means, what a pre-petition screening is, and what, I think that would be helpful just to have some context.
I'll go ahead with that. A pre-petition screening is when a doctor will see that a client will need, a patient in the hospital will need to have court intervention to force treatment. Maybe looking at drugs or other services that the client needs, and we go to court and go through a court process to help the client get the help they need, that they're not recognizing they need that help. I don't know if I have a real systematic reason why those have dropped. I think we have tried to enhance some of the services that we offer individuals, so maybe that they're getting the help that they need and not needing to come back into service. But I don't know that I have a particular indicator, one indicator that would.
Okay. So the idea is, we've done that
service,
once.
The whole service network is able to give them the support that they need.
Okay.
And not needing to return.
I noticed the drop too, and I was really happy to see that. And I think some of the explanation for that could be that we as a county have had the opportunity to put some other innovative programs in place. Treatment court, some individuals that are participating in that might be people that we would have seen for a pre-petition screening. And I also think that the case managers do an excellent job of working with their clients when they have a commitment with them. The commitment expires typically after 6 months, but it isn't uncommon that the client wants to continue to work with the case manager on an ongoing voluntary basis.
Mm-hmm. Just a follow-up question to that same graph. Do you know, you mentioned something, Jody, about the treatment court. What do you think the impact will be when we have a vets court, and knowing some of the mental health issues that plague the vets as they come back from service?
I think it's going to be an even greater impact. I think we potentially could see our numbers go down further. That's what I'm hoping for, so that's what I'm expecting that we will probably see.
Jody, just as a follow-up on that, are there things that that you see from your perspective, like areas to build on, to sort of support those people in a better way? Like, it's really strong performance, but are there other things we could be doing?
I do think one of the things that's really important is because the county now has our own dedicated crisis team, I think that it's important that we spread the word about letting people know to call them. We call law enforcement regularly as citizens, but I think the more people that know about the crisis team, the better, because it's not criminalizing mental illness, but also it's yet another resource that we have in-house to help folks. So I think that would be something that would be helpful on it. That's the first thing that really springs to my mind.
I think another thing as a group that we've talked about a number of times has been around that total number of pre-petition screenings. And so are there things we can do prior to someone getting to that point? I think we hope to be preventative whenever we can. I think we've done a really good job of building up sort of those deep end services, but a lot of individuals in our community don't quite qualify for those. Maybe they're not interested, or they might not need that level of service. And I think we have been strategic about making sure that we're only serving people at that level that we absolutely need to. And so what can we put in for prevention to help it?
I think the outreach position is really key and important here, and I'm really happy that that went through. It's not uncommon that we speak with citizens and they don't meet the level of services yet or commitment, but yet something needs to happen, and so that's a really great precursor.
And can we just clarify, is the halftime outreach worker, is that a county employee, or is that person associated with one of the private agencies?
That person is employed by Guild Incorporated.
Okay.
And this is the first outreach that we've had in our community. And it is specific to individuals who are homeless. There's a high focus on long-term homeless, but it does, I think, meet some of that need. I think we would still like to see some general outreach for all individuals who have mental health needs. I think a lot of times we'll get reports from the community or family members or others who are concerned about an individual. But right now, the only mechanism that we have to send someone out to them is if they are meeting that criteria for the mobile mental health crisis team. And in that instance, they also have to be willing to receive services. So we don't have anyone who can go out and try to engage someone and get them interested. It's sort of like either you meet this threshold and you're really interested to move forward, or we have to wait until you get to that level.
Jody, you talked about the difference with law enforcement going to scenes. Can someone walk through the difference between what we see on page 7 with the percentage of individuals in crisis offered services within 4 hours of request? Kind of talk about what that slide does for us, and then compare that with page 10, which talks about the law enforcement mental health events that were pulled from the system. We talk about what's causing the difference in numbers between those two slides, and should it be that way, or what are the strategies that we're implementing to close the gap there?
Maybe I can field this at least first. So this figure comes from the Mental Health Center statistics, the first graph on page 7. And those are individuals who call the Mental Health Center or a family member calls, and we get them in for an appointment within 4 hours. The percentage, which you can see is really high. It would be higher, some folks choose to wait longer than that, which are not necessarily the same, all of the same folks that law enforcement is dealing with, because these are people that call us and ask for crisis services.
And so when we're looking at the information from law enforcement, those are people, and Sheriff Henning can certainly speak to this much better than I can, but those are people who are contacting 911 because they have a mental health need. I think when we see that, that says to me, that's the last resort. I mean, you are desperate usually at the point when you're calling 911. And I think those numbers are reflected across our system and the need that comes out in those 911 calls on page 10. But what I would compare that data to is page 12 as well, with the numbers related to our mobile mental health crisis team. I think our hope is that our community members can contact the mobile mental health crisis team instead of 911, or that they can get their needs met prior to that. So the dispatch data tells me that we still need to do some community awareness and engagement about Canvas so that people know that that number is out there and they can get a mental health professional to actually come out to their home and do an assessment and provide some short-term supportive services.
And one thing I would note on the 911 calls is what we used to see is a lot of repeat calls. So we'd go to the same house multiple times in a 3-day or a 7-day window because of that crisis. So I question maybe there is some intersection there where we're going, but also getting them some resources and not going back multiple times, but getting them in touch with the right people. And that would add up to the time we started sending more of our deputies to crisis intervention training. And through that training, that's where they get a lot of the knowledge of how the whole system works, not only how to de-escalate, but also how the system works. So in 16 is when we still really started ramping up, and then 17, 18 is where we sent every deputy to that training. So there could be a correlation there as well, that because I do feel we don't hear about those consistent calls anymore, especially now with Canvas in play. We don't hear the deputies or the officers complaining about that, geez, I keep getting called to the same house, I have no resources or tools to provide them. It seems like we get that call and then we don't get the further calls because now Canvas takes over that follow-up and provides those services, as well as I know when the deputies on scene are providing services, or even before Canvas here, going back to the house when they're not in crisis and explain to the family what some other tools are versus waiting until it gets to the point that a police response is needed and or arrest is needed, but helping get some resources in early. So there's some possibilities there that could explain.
So I have a question, and it doesn't really pertain to any kind of graph, but it's more global. And yeah, when this topic came up, I kind of was Googling all different types of things, looking at trend data, and it's amazing the amount of data that's out there. But I mean, all of the data that I've been reading was all talking about awareness. And it's not only awareness for the person that is experiencing mental health, but it's also an awareness of everybody around them to be able to identify it early. And my question is as you're going through your strategies and as you're looking to make improvements, what is the methodology that you use in educating just the general public on mental health and mental health issues? globally, and I look at the trends with teen suicide and even adult suicide and trying to get in front of that, I think most of us know someone who has some loved one that's committed suicide, and I'm like, how do you get to be people to be more aware? So can you tell me a little bit of the strategies that you're undertaking, not to address something maybe very targeted, but globally for me to look at people, and if I see, because I'm educated, and maybe things that it kind of mirrors like a mental health issue?
I can, I'm sorry.
Yeah, that would be great.
I can start. The Mental Health Center does a lot of training. I think last year we did over 50 trainings for the public, the schools, social services, different departments about mental health awareness. We did one, or I did one with FISH around suicide prevention. I think we did 7 with the different school districts about suicide prevention. This fall, alone before school started and shortly after school started, we've done 6 in the school districts about mental health awareness, symptoms, what that looks like in the classroom, reducing stigma, and suicide prevention. But we're always letting people know whenever we have the opportunity that we're eager to come out and do trainings on various topics. And so that's, from the Mental Health Center standpoint, that's what we're doing.
Just one follow-up. What kind of like social media do you use, for people who are out Googling? Some people are big Facebook folks, and so they're out there and then they see maybe some session. Do you use all the different types of social media, or do you have any idea even of attendance or number of hits, how interested or how direct people are in trying to educate themselves?
I think we have tried to utilize social media so that there's an awareness about the programs that we offer services for. And so Lisa Koner has been helpful in getting things posted out on neighborhood sites on Facebook and all of her other venues that she does that with. I think we would certainly love to see more community awareness across Scott County and across the state and across the nation about mental health, because I think that has been something that our community continues to bring up. And so Terry's crew has been able to offer wonderful trainings, but I think it would be great to see just more general community awareness. Absolutely.
Thank you.
Sheriff, I know the Vitals app is new, but I'm wondering if you could talk a little bit about how your office is experiencing that and kind of where you see that going forward and how it impacts all this.
Yeah, so the Vitals app is something we started, went live I think a month ago. It's basically all of our officers now on their smartphones have an app that when you get within 80 feet of somebody with a beacon or the application or one of the devices sold by Vitals, they would get an alert that would provide some basic data on that person that would say, this is my son who's on the autism spectrum, or this is somebody with persistent mental illness, choosing whoever they want to sign up and provide that information. So a classic example would be a mother with a child with autism may create a video on the app that we'd be able to play to the child if we see them wandering or they're in distress. With mental illness, it may give some techniques of how we should speak to them or respond to them, or it might say they're more comfortable with a female officer. It could be whatever they choose, as well as contact information for loved ones as well. So we may not have to even engage that child. That's maybe a suspicion call in the park that everybody's like, what's that kid out here doing by themselves? We may get within 80 feet and go, oh, now we know what's going on. We can call the mom and she may say, oh, I'm across the street. I know he wandered over there, versus getting into some type of use of force or interaction with them that isn't even necessary. So our main goal is pushing it out, is trying to we need the clients to use it. So now the deputies have it, but chicken before the egg type thing. If we get it, my thought is then hopefully now the clients will start using it in some of our services, and it'll be another tool that'll help us engage them and be aware. And with our entertainment venues as well, a lot of our bigger communities like St. Paul, Ramsey County have been doing this for a couple of years. We know we get a lot of visitors to our entertainment venues. Our deputies may interact with somebody from another community that has that application. So it's a good tool to have, but it's also takes a while to get that trust built up and people to get out and get signed up, but hoping there'll be some success stories to share soon.
Is there and right now that's just in the Sheriff's Department, is that right, or just
yes.
City? Okay.
Just the Sheriff's Office is enrolled.
So is there a plan for that to go broader, or
the police
maybe?
cities are all aware of it. We've talked about it for a couple of years now.
Okay.
That's the presentation.
Okay, thanks.
We're also talking about the crisis team getting it too, so that we can help out if we're on scene, and somebody needs extra help. So, and we're working with the sheriff's department with that. We might add on to their app that they already have.
Yep, we're gonna add a few profiles for
Yeah.
them to use, and that'll be another tool that
Oh, nice.
would give them information too if they go to call. It's,
Karen, does your team, when you go out, do you always go with someone from law enforcement?
No,
or you never
we
go with-
rarely go with law enforcement. They're there if we need them, and we know that we work really closely with them. But we very rarely go out with law enforcement. Typically, my team goes out by themselves.
Okay.
Yep.
Okay.
Can we shift to page 13, the outcomes for case management referrals? This was kind of surprising to me that of all the referrals we have, we only have about a third that are actually converting to case management. So I was just curious, what are the reasons for that? What happens to those folks that we don't get into case management? What, is there other things we're doing? So.
About a third of the clients do go into case management. I think about a third of the clients may either not decide they don't need the service, or they may get their needs met while we're working with them in the assessment. Sometimes clients might need some help getting on like medical assistance or some type of program, and once that's done, they really don't choose to go on for services. This data is really going back a little bit. I really think our 2019 data will show that we are engaging more clients. The intake department has done a lot of changes, trying to outreach a little bit better and make sure that people make appointments. I know we had trouble with getting people to appointments, remembering appointments, and so I think some of the changes they made are going to actually improve the stats of the number that make it to the through the assessment process.
You can see that chart is also tied very closely to page 14 and 15. So when an individual calls in to case management to request services, there are a couple of touch points before they actually get assigned to a case manager. So someone calls in, page 14 is the amount of time that it's taking us from that call to get someone out there to do an assessment. So right now it's about 30 days after an individual calls in and requests services. Within these first 30 days, we're seeing about a third of those people drop off. Then if you go to page 15, that's the second step. If they meet the assessor and it's determined appropriate, this is the timeliness of getting connected to a case manager. So from the day that you call, it's taking about 60 days till you get assigned to a case manager, which then will take some additional time to get that case manager actually out to do a face-to-face. So as Lori said, some of that is because maybe people aren't interested, maybe they're not appropriate for services, maybe they get their needs met, but I think we also suspect that there's just some disengagement, particularly for our people who are experiencing a lot of mental health symptoms. I think it's challenging. And these 60 days are a barrier for people getting into services. We also have right now a pretty full plate in case management. I kind of alluded to earlier that we have been really strategic around the cases that we're taking into case management to make sure that they in fact need it. Part of the reason for that is just because the team only has so many slots, and it's taking some time for us to find some availability on those caseloads right now.
Do you have a goal in terms of days to the interaction? Is there a state average, or is there a goal that you're trying to get to?
There's not. I think I would really like to see it be within 30 days of having somebody call and then get assigned a case manager within 30 days. There are steps that need to happen within that as far as getting a diagnostic assessment. But in the meantime, even if it is 30 days, I think those people still have a lot of needs. And so my hope is that someday we would have some general outreach staff that could provide some engagement to those people within those 30 days to try to get their their immediate needs met. We also have our Anchor Center, which is our mental health drop-in center over at the Career Force Center. That right now is only open 2 afternoons a week. So ideally, people in that waiting time, or maybe if they're not meeting that criteria for those deep end services, could go to that site, meet with some of our team members, and get connected to services, as well as have a community. I think part of some of the challenges we see with mental health is there's a lot of isolation. And so when we pull people in and engage them with activities at the Anchor Center, I think we're less likely to see a need for some of those deep end services.
To follow up on the question on the people that aren't, the grid on page 13 of people that are not interested or no show or not eligible, et cetera, or decline service, do you still track these folks knowing that there was a call at one given point and whether or not their needs were met or not met, or how many of these people do you see post the initial information that you receive?
I think when we look at the data, and this team has really done a lot of work to dive into that information, and they created a beautiful spreadsheet that we were able to go through even line by line and see what happened with individual cases. We see people coming back time and time again because maybe they felt like they didn't want services at that point, or maybe things got worse and now they needed to come back, or maybe it was that waiting period. So different things are happening in people's lives, I think, but we are seeing people come back, and sometimes when they're not able to get their needs met, those needs have then gotten more intense, and those, I think, are the individuals that we see end up in pre-petition screenings or in some of the institutional settings.
Do we know anything about, is there any commonalities between the people who don't follow through? Like the people in that third that?
I think from my perspective, that is somewhat unknown because we don't have that outreach component that's going out and engaging with that person. And sort of knocking on the door and saying, are there ways that we can support you? Is it a transportation issue? Do you just need to get more comfortable with thinking about accessing the services? I think that's an unknown. I think this is really good information, but we would like to see more depth to that, yeah.
So potentially another function for that outreach worker is understanding some of that why people. Okay, nice, thanks.
Karen, I was curious, you're about a year and a half into the Canvas program, I think, if I remember right. What's been the most challenging aspects for your team?
I would say staffing. We just, there's not very many of us, and I think people think we're like this huge group, and we're not. So it's always a juggle on figuring out who's going to go where. And then I think one of our biggest things is transportation too. We don't transport clients at all. So especially if we go out and do an assessment on somebody and they need to go to a crisis bed, if they can't drive themselves, which is usually the case, we try to find a family member, neighbor, friend, anybody to drive them. And we've had several situations where there was nobody. And as people are aware, our nearest crisis bed is quite a ways away, and the one we have the most luck with is in Mankato. So that's quite a distance to try to get people there, and then, of course, back too. So I think transportation's a big piece, and just not having enough staff. I mean, we're busy all the time. So I'm seeing our numbers really increased since September of this year, with school being back in session. So. Yeah.
Which actually is a good thing for us administratively, because I think when we were first forming the team, our numbers were so low that we had a hard time demonstrating that need because we weren't having people access the service. And so our hope, I think, is that we will be able to advocate for some additional state funding now that we're seeing these numbers increase and it being consistently busy, as Karen said.
Karen, can you talk about the time of day that you're receiving phone calls, kind of your workload as it's spread across weekends, nights, holidays, traditional business hours, and how you manage that?
That's a great question. So I don't have the data with me today, but we get calls all sorts of times. I would say a good chunk of our calls do come during the workday, and I think part of that is because that's when my full-time staff are working, is during the workday. But we definitely get calls weekends, evenings, Holidays. Labor Day this year was extremely busy for us. I I'm not sure why. Like I said, I think September 1st hit, and then like everybody decided that they needed mental help, which is great. I mean, we want to be there for people, but I would say a good chunk of the work we do is done during the day, and because we're working with people in crisis, I think it's smart that we have our staff there majority of the time during the day, because they want to meet with us during the day versus evenings and weekends typically, especially in crisis. So we're able to get a lot of that work done through the workday. I'm not saying we don't do stuff after hours, we certainly do. And if somebody needs to see us in the evening or weekend, of course, we'll see them. It doesn't matter when they need the help, we will definitely get there. But I would say a good chunk of our phone calls come in during the day.
How does the service differ then from when you have your full-time staff on during the day versus after hours? How does the response, impacted from your perspective?
So our response is always, we usually get to the point to do the assessment within an hour. The state guidelines are to try to get there within 2 hours, and so we usually get there within an hour. Our after-hours staff are all on call, so they work out of their homes. So depending on where they live, they have to be within a certain radius of Scott County if they don't live in Scott County to respond. So they are, ready to go. They're not coming from the office here, so sometimes there's a little bit more travel with that, but that hasn't been an issue. We do have another group of people who answer our phones after hours, and I think it's First Call for Help, 211, and they have specially trained staff in mental health crisis. So they have been triaging our calls well. I don't feel like there's been any issues with people not getting what they need after hours either. So.
Then one last question about Canvas for now.
Yeah.
You talked about not having transport capacity right now.
Mm-hmm.
If you can't find a friend, family, someone to provide that transport with, what are your alternatives? What do you end up doing?
So that's a great question. So part of our initial assessment with clients is doing a safety plan. We actually do a very robust plan on how to keep them safe. So it may be, can we keep them safe until tomorrow when they have a ride? If we don't think we can, they may need to go to the hospital to get, unfortunately, another assessment and then be hospitalized. If we do end up having to send somebody to the hospital, we have really good relationships already with the hospitals in the county. We will call ahead so that they know they're coming and give them a full, pretty full clinical details on what's happening. But I would say that doesn't happen very often where they have to go to the hospital. We're usually able to figure out an alternative plan. But there's been a few lately that have been really hard, and my staff has spent like many extra hours just trying to figure out the transportation piece. So, yeah.
So I have a question about one of your challenges, what's not working well is the lack of accessible and affordable mental health services across Minnesota. And again, me reading up on this they really talk a lot about insurance industries and insurance industries saying, we don't cover mental health issues. And is there, number one, from a state perspective, do you know any initiatives to address the insurance of affordable health care, including mental health? Is there any initiative at the legislature or some other fashion to try to address that? And in addition to, when you say lack of accessible, where are the mental health centers in Scott County? And are we seeing that there are those that are they not accessible because the amount of time that they're open, or are they just not close to anybody? Or people aren't close to a center?
Any of you can
Yeah,
probably
sure.
really speak to that. We would love to see, I think, some energy around the legislature, but I think that the health plan coverage of mental health services for our team internally has been a significant challenge because there are many plans that just don't cover things. For example, our mental health case management. But, I mean, you guys all probably have really good examples of that.
I can speak to, so for outpatient services in Scott County, we're in a really good place. The Scott County Mental Health Center accepts all insurance, MA and Medicare. So for a lot of people, if they're on Medicare, which a lot of our SPMI clients are, there aren't very many providers that will take Medicare because the payment is low, but we do. We don't, have a limit of Medicare clients that we will take. And so for outpatient services, we're in really good shape here. There's also outpatient clinics, kind of across the county, even in our smaller communities. But we have struggled with, that's like IRTs and inpatient, and particularly hospitalization, hospital beds. And I think Lori can speak to that more.
Yeah, that's a real problem with some of the insurance plans, like we want to send someone to a IRTS program, intensive residential treatment program, and if they're on a private insurance, their spouse's insurance, or some of the clients that work, they won't cover that. And so we're trying to look for services in the community that can support them, and often there really isn't any. Things like the ARMS programs, the rehabilitation services don't take private, can always be service for private individuals. So we're trying to find a resource, or oftentimes we just have to try to fill that gap ourselves because there isn't a program that we can plug in.
And I think people who speak English as a second language is another challenge, to try to connect them to culturally appropriate people. We just don't have really many people in our county that speak other languages, especially therapists. So that's something that we've run into. Trying to find them a resource, and oftentimes we're sending them up to the cities for that type of service. And then transportation becomes an issue for that too frequently, so, yeah.
Beth, I wonder if you could talk a little bit, one of our aspirations is to have more partnerships like the one that Scott County is forging with Guild, and to be able to bring private agencies in to partner with us. And I know, I think Danielle said they're just putting up 2x4s in your building, so it's a little early to talk about program outcomes. But can you talk about, were there things that we could learn from in terms of engaging a private organization such as yours? Were there pieces of the work to build that partnership that you had found helpful, or maybe where there were some gaps?
I don't know if Danielle might actually be able to answer this a little bit better. I have come on more recently.
Okay.
But since I've been on since February, I would say the experience has been really great. I mean, Danielle and Pam are available. We're meeting with them regularly, talking with them. So I feel like it's been a really collaborative approach, and I think that Guild is excited to be here and would love to provide an array of services in Scott County. I think we're hoping that the IRTS in Crisis and our outreach worker is just the start of that. I think a lot of the things that we've talked about, barriers just in general, health insurance, transportation, those are barriers just that we're all facing, and those do get in the way of the collaboration. But I think it's an exciting opportunity, and I think a lot of private providers like us and like Canvas do want to and see the importance of partnering with counties so we can best serve our folks.
Nice, nice. Are there any things, Danielle, that you would add to that in terms of what we could learn about fostering an environment that would bring private agencies into Scott County?
I think our initial meet and greet with Guild took place at our local mental health advisory council, and just sort of those beginning conversations and finding an agency that's mission driven. And I think a lot of times we identify a lot of barriers of why someone isn't here, but I think when there's been commitment on both sides to just work through whatever those issues are, sometimes it takes a while, but we're able to make it happen.
Are there things we can replicate?
Well, we really hope that there's a pot of gold out there like there was with the state funding that we received for the IRTS facility. But I think just that ongoing communication was essential for us to make that work.
Okay, thanks.
We've been talking about private insurance. Does the data that's in the packet talk about just the services the county's provided, and how is the interaction between those who may seek private services and at one point in time then interact with county services? How does that work? Are we tracking those who are seeking private services first? And if someone does start in the private sector getting help but then comes in to get more assistance from the county, how do we know the history that the person's gone through, and how do we manage the back and forth? if that wasn't too convoluted of a question.
Well, I can speak to that regarding, because we are a provider for pretty much every health plan, and MA and Medicare, as I said previously, and then we also offer a sliding fee to those who don't have insurance at the mental health center. So we have a lot of interaction with folks that have used private providers. Every service starts with the diagnostic assessment, and part of that assessment is to contact all of those previous providers to make sure that we have all the records and that we've reviewed them so that there's no gaps and that there's, no missing pieces or a wrong diagnosis per se for the client.
And I think we really value those private network providers because I think it takes the full continuum to make that work. When we're talking about county services, typically those services are focused on individuals that can't access that private network for whatever reason. It could be individuals who are on medical assistance and need support. It could be individuals who have such a deep end need of service and that the county is mandated to ensure that that's covered. For example, like with the crisis team. So I think we try to partner with those networks as much as we can to make sure that our overall community needs are met.
I have a question about, on page 16, you have the CASI, or CAS2, I'm not quite sure how to say CASI scores. Looking at these kids and knowing that they've experienced some level of trauma, my question is, how or can you engage possibly other departments when emotional issues exist within a child? Maybe it has something to do with chemically abusing parents, just other type of home situations that may also impact their ability to continue to improve. And by the way, I did want to say from 2012 to 2018, that's a substantial increase. And so good job there. And the questions are, how do you continue to improve that? And what type of ability do you have to cross-share kids' information across multiple venues to make sure that these kids their issues are being addressed?
Children's, that's a whole nother area.
Well, you were pretty quiet, Steve, so I thought I'd make sure that you were playing the game with the rest of them.
The CASI score, so we're dependent, anytime you do, case managers we do the assessment of needs, we engage families to, in terms of what they're looking for, help them identify goals, where they want to go. And then we're really looking for the mental health center, we're looking for community supports to plug them into in terms of, so we're developing plans so that they can get the services that they need. So it's a cooperation between case management and the community service providers, and the service providers are the ones who really kind of drive the CASI. So we do that kind of in cooperation. So if we identify the needs, we get the services in place. The hope is that we're improving CASI scores. And so case managers are doing exactly that. They're coordinating the schools, if there's a probation officer, if there's often with crisis team in terms of developing crisis team plans and making sure that they have that information. Sometimes it's with older adolescents and we're making the handoff to adult mental health. And so that is the job of a case manager, to make sure that they understand the needs, they understand the services in the community, and that they're doing tight communication and coordination with those service providers. And that's a lot of work. Sometimes you're right, the parents themselves have their own trauma, their own chemical abuse issues, or they're just, they may not have a trauma or a serious mental illness, but they got 5 other kids. They may be a single parent. They may be a parent who has divorce issues or marital issues, and all those things impact CASI scores. CASI scores have to do with safety and child functioning and family support, family disengagement, child engagement, and so there's a lot of different scores that can drive a CASI. You can do really well in other areas, and if safety is super high, that can drive a CASI score pretty poorly. So it takes a lot of finesse for case managers to engage a family. It doesn't matter how many services are available, but if you can't do a good job of expressing concern and care and helping them understand that you understand what they're asking for and help them move along at a pace that they're able and willing to do that. It takes a lot of finesse and skill and a lot of support.
So are there barriers with working sometimes with parents who a child is maybe being reported as potentially having a mental health issue and the parents are more disengaged, or they don't really want the county intervening, government stay out of my house type of thing? What do you do, or how often does that occur, and what are your challenges, and how do you impact, or do you have to remove the child, or how do you move that forward?
But Children's Mental Health is a voluntary service, so we're always reaching out. So we can get referrals by hospitals, mental health providers. Unfortunately, those are the ones that often don't connect because sometimes they may not know a referral's been made on their behalf, or they're just not ready to receive the service, or for a lot of families, they're already plugged into psychiatries and they're plugged into outpatient therapies, and so they may not see the reason why they're doing that. So there's lots of reasons why families don't get connected, but there are some families who maybe have had a poor experience or they face the county, so there's a lot of barriers in terms of how do we do that well. We do calls. We let them know that someone has made a referral on their behalf and they're concerned about them, and we're available to help you. And if you want the service, here's how you can contact us. So we'll make a number of different telephone calls, and then we'll also send a letter out to let them know that we've reached out. And if they don't call us back, we're offering some sort of services.
What percentage of those families take you up on it? You said this is something that you offer that's not mandated, that you're offering it as a courtesy service to these families. What percentage of kids or parents don't become engaged? Do you have that statistic?
Ours is probably about 40-60. I think 60% receive the service, 40% don't get connected, or don't feel like there's a need. Or maybe open an assessment work group and work, because there's always the demand, coaching case managers to assess, is there a need for case management, number one. Not to assume that because there's a referral, we jump in and do a 6-month plan when it's not needed. And so how do we use resources and our own resources in a responsible way? So sometimes opening may be a good decision.
Can you share that openly with the schools, or is there has to be an authorization? I guess looking, if they don't want your service, at least there's a school mental health professional, I think, in most of the schools, or maybe not.
Yeah, I can speak to that a little bit. So, of course, the parents need to give permission. We don't go and do therapy with them or a diagnostic assessment without the parents wanting that and being part of that. Last year in the schools, we did 385 diagnostic assessments for kids. And all of those involve an assessment for trauma. We also did probably 25 to 30 trainings on trauma-informed classroom and trauma-informed school. The schools are very receptive. We're working also with public health nursing regarding ACEs and helping the schools kind of understand how a child presents differently when they have trauma. And the schools have been wonderful partners on that. Regarding parents, just some of the kind of things we've done lately, always, like I said, we involve parents in all of that. And they're involved in a treatment plan every 90 days. They come in and we talk and sign the treatment plan and the goals. But some of our more recent projects is we have a grant. We've received 3 grants from the state for trauma-informed care for students, and they're programs that are evidence-based, and we've been implementing those. They're at different levels, high school, middle school, and the one we just got is Bounce Back, and that's for elementary-age kids. And part of that program is a component for parents, where you bring parents in, and they learn about trauma and other mental health symptoms and what those might look like with their kids. And then it also involves groups for teachers. That's been very well received. And a second project that we did last year, also grant funded, was we did groups for preschool parents. It was great because we were able to, because of the grant, have childcare and have a meal for the parents or the families. And the whole topic was understanding the connection between trauma and other pieces and your young child and how that might look in terms of mental health. And that was very well received too.
I think another part of your question, Cindy, was just around that shared data and how do we work together. Many of the supervisors from these teams come together on a monthly basis to talk about how things are going, are there cases that we can talk through, and data sharing has definitely been a topic of discussion. You know, I think we want to make sure that we are providing the best service possible, and having information can really inform that. But we also have to be respectful of the legal implications of that and the privacy of that individual. So I think that's something that we continue to work on, and I think we are trying to create systems where we can effectively share data and agreements. But I think beyond the individual data that's being shared, really the trend data that we're seeing from all of these teams and looking at that collectively has helped us identify some of those service gaps and really get the full picture. I think we, as the county entity, only have one piece of this pie, and so having more information from all those partners has really helped inform our actions.
Thank you.
Before we turn this over to the audience for some questions, I just wanted to, you've all spoken really clearly about challenges in transportation, some insurance barriers, and the need for some public awareness building around the crisis team. As you look forward into like the next year, say, as your team looks forward into that, are there other things that you're going to work on? Are there gaps or weaknesses within our crisis mental health service array that draw your attention as a priority over the next year?
Well, I think we've spoken about the outreach and engagement need, and really just that need to try to engage individuals or engage families, whatever that may be, through community awareness or through mechanisms like people who can dedicate some time to doing outreach. I think we are really interested in how we can decrease that time that someone is waiting from when they express that they want services to actually get them in the door, if that's appropriate. And part of that is that capacity on some of those teams. I think we have had a lot of conversations about mental health and the overlap with homelessness, and so exploring what might be some options so that when we have really vulnerable individuals, we can find a way to meet their needs immediately. Other thoughts for the next year? We also are working on exploring jail diversion and what does that look like. And so I think we're in the beginning exploration stages of that. I think it will probably take us more than a year, I would assume, but I think that's one thing that we're excited about learning more.
Nice. Thank you. Questions from the audience?
I have one question just in follow-up to that, Danielle. One of the things on page 2 that you identify is an ACT team as a gap, and just for the audience, because I'm sure not everyone knows what an ACT team is, but then more specifically, my question is, we looked at this a while back, probably when we did the original board strategy work, and at that point our numbers didn't support that we would have the numbers to support an ACT team in this community. Do you think that has changed at all, and do we need to be looking at that?
I don't think we've seen a drastic change in the numbers. I think what we're seeing is just a lack of those overall community supports. And so I think an ACT team has been a resource that has served some communities, but because of our size, we probably are not going to be a good fit for that. Could we potentially partner with another community to have a joint ACT team? Potentially.
Can you tell folks what an ACT team is?
Sure. It is an assertive community treatment team. And so some larger communities have these teams where they have a nurse on staff, they have a psychiatrist, they have outreach workers, they have mental health professionals, and they really focus on those really high needs individuals and sort of wrapping them around with services and connecting them very quickly to help connect them to housing, to transportation, to ongoing services. Maybe they would be utilizing the crisis team or the IRTS program. So it really is a really high intensive group, and I think they only maybe work with caseloads as low as like 20 individuals. But we just have not seen that level of need yet. I think we will want to be mindful about what that's looking like in the future, and does that need grow for us?
Does Carver County have an ag team?
They do not.
So would there potentially be some partnership there with Dakota or Guilds in Dakota?
It could be a potential. I think there's concern just around the size of that coverage area, but I think definitely worth exploring.
Okay.
I do think right now that the crisis team provides a lot of that. I'm not saying we're an ACT team, but I think when you look at our data, we do a lot more stabilization appointments than we do assessments, and I think it's because we're providing them with a lot of services to get them connected to the right people. So I think if we, it's all about balancing. We certainly can keep doing that, but our capacity is getting pretty full too.
Other audience questions?
I don't want to talk into a microphone, but I'm a case manager with the Adult Mental Health Unit, and I do the assessments. And so I just wanted to follow up a little bit. I think you had asked about what the reasoning might be for that large, like a third of people with no contact with us, because I'm the person that's doing this and gathering the information. I just wanted to say that the majority of those folks, I would say, are not self-referred. They are referred by someone else. So a lot of times, like the hospital, if they're in the hospital, the social worker will just make that referral and not even tell the client. And so when I follow up with them, they're not interested. They don't even know what we do. And so that might also attribute to the recidivism piece, that maybe they heard about us and then later on they come back. So simply that they were referred with no contact doesn't mean that there was a failing in the system. It was more like the source of the referral. And that we do have this data, but if people refer themselves, the follow-up is very good. The other piece of that I wish we had the slide, because I'm happy about this, in 2019, that would look a lot different as far as the outcomes, because we have 52% of people coming into case management now this year so far. So it kind of speaks to the outreach piece of it that we are doing, more calling more often, reminding people of appointments by texting them, and just more assertive in that way. And so people are able to follow through more with those reminders. So I just think that's important to kind of note that those changes, they are happening. Mm-hmm. But we do only have, I only do this part-time, and I'm the only staff that does it. So when you look at our numbers, it's a lot of people. And so it's challenging to engage people quickly with just time.
So I have a question for Dr. Raditz and Lori. We had three, through the building assessment and discussion for space, 3 units really talked about a need to change. One was the Anchor Center, one was the Mental Health Center, and the other one was Public Health. And I think those are really being accomplished through the new building. What, Dr. Raditz, does additional space, right now you have like 6 rooms and it's hard to shuffle people. What will that mean as we have a baseline now moving forward to helping move people and hoping into the system sooner? And the same thing to you, Lori. What is that Anchor Center and the space revisions going to mean to folks with mental health issues moving forward?
Well, for us, it means a great deal. We can see more clients at the same time. We don't have to wait to schedule people because we don't have space for them, which is really critical for us. And it's also a contained space, which is really helpful when some of our clients are involved in other departments, but not necessarily in a way that they love. And so they have a little space now, so they're not in the same waiting room with, maybe seeing a worker that they were involved in a conflict with. So, yeah, we're very happy. Thank you.
What will the capacity increase be, do you think, in being able to see people or to move them through? Have you done some looking at that now over the next year as we start to plan to move?
Yes, well, basically, we can see Right now, we have 6 rooms where we can see clients, and we'll have 15. Where right now, we can't do groups in the mental health center. We have to go somewhere else in the building, and we can only do 1 group at a time. We'll be able to do 3 groups at a time. So we really will be able to hopefully see everybody that calls in at the time that they want, if the therapist is available, rather than, right now we have to schedule a room, the therapist and the client all have to come, have the same times open, because they have to share all those 30-some FTEs. Now, some of those are in the school, but 30-some therapists share those 6 rooms to see clients. So, yeah, it's going to be, I think, really capacity building in terms of our services.
And both of those facilities, I'll let Lori go next, have their own access and independence, so talking about trying to design it so it fit the needs of your clients as well.
And that's what we're hoping with the Anchor Center, that we'll be able to have maybe some evening or weekend activities, things that we aren't necessarily able to offer now. I think our biggest need would be, as we move to the new building, though, would be to increase our hours. Right now, we have like an open drop-in that's about 6 hours a week. We have some special activities, but really, we could be a resource to people throughout the week and really accommodate people that work and have some evening activities, but we just don't have the staffing to do that at this point. So we're hoping in the next few years, while the building and the renovations are happening, that we're going to be able to increase our funding to be able to be open more and offer more services to individuals.
So I have just a general question. Can any of you share your experiences with successes in reaching out to diverse communities? When we were doing Shakopee Diversity Alliance work, we found that some of the groups were pretty reluctant to ask for help or to want to admit that there was such a thing as mental health problems or issues. Are we trying anything that's effective, or are you aware of some initiatives that have worked well?
Well, I can speak a little bit to our services in the school, our Connect program. It seems to be a really nice common ground place for people to get services. We have substantially higher number of folks taking part in those services in the schools in terms of people of color and diversity than we do in the mental health center. But that builds trust, and so we've had experiences where, because of the trust was built in the school, then the families are coming in and requesting services in the mental health center. And we've done some of the programs I was talking about with like parent support and parent enrichment around education, around mental health. Those have been strongly attended by our communities of color in the schools.
I think we've really tried to be strategic in how we move forward with our planning and consulting the Diversity Alliance or the Shakopee and Mdewakanton Sioux community around the development of the IRTS facility. I think we do still have some work to do there, and I think we have some data to look at. One of the things that we talked about as some of our next steps with case management is for those folks who are dropping off of services, is there an impact to race or other diversity factors that are playing into that? And then what can we find out about how we can improve our services so that we can be accessible to the full community?
I have a question about data sharing. Having worked with the legislature, I realize that they are not going to approve any data sharing without patient or parental permission. And so are there other barriers that currently create silos? Can you ask for that permission and get it from the patients so that you can share? Are they reluctant to do that, or are there actual laws that prohibit you from doing that?
Speaking from the legal side of things, there are laws that do prohibit us from sharing confidential data, even if the subject of the data does agree to have that data disclosed. So we always have to make sure that we're consulting the statutes. before we're answering questions about that. But there are other instances where the subject of the data can consent to having the data disclosed and shared with other departments within the county or entities outside of the county as well.
I think we also see barriers just in mechanisms that allow us to share that data when we have the permission and the authority to do so. So most of these teams are working through different systems, and so it can be challenging just to transfer information from one team to the next, even when we do have permissions in place.
Hi, I have a question about crisis services in the county as we've transitioned to our own team instead of the collaborative team. The after hours piece with crisis and Canvas, just wondering if there's any plans to make that a more smooth transition to after hours and weekends. Right now, when you call, you do get 211 and you have to relay the information to them, then they dispatch someone else who may or may not go out in person. So wondering if there's any opportunity to expand what Canvas can do as far as mobile crisis assessments or assessments after hours that's not through this like third-party system.
So when we developed that system, we really had to be creative. At the time of the new team being implemented in Scott County, there were some significant funding gaps across the state, but I think in our community, Canvas was running a statewide phone triage system, which was then defunded by the Department of Human Services. And so that system initially created a lot of efficiencies for us and other communities to be able to tap in to that line and the staff that were already working on that team. When they lost that funding, there was a big line item that was missing. In addition to that, when we applied for funding for the crisis team to the state, we did not get even half of what we requested, and I think we requested conservatively. So at this point, I think we are making it work, and we hope to advocate for some additional funding, but those are just sort of the limitations that we're living under with the state grants.
All right, Madam Chair.
Thank you, everyone. What a great presentation. It's so good to see our progress on this issue, on an issue that was identified. I know we have some comments from the board. I'll start with Commissioner Wolf in just a minute. I want to clarify one thing, just because all this data we present, sometimes with public or media or things, I see little pieces of it picked up. I do want to just confirm. So when people are calling our crisis hotline or they're calling the mental health center, the data's in here showing that they're, either within an hour or 4 hours, almost always helped, gotten some resources, that type of thing. I just want to make it clear that the data being shown on case management, those are people who are looking for more intensive services, who qualify for those intensive services. It's a subgroup and can't be getting those other places where we're looking at that 30 to 60 day wait. So very different. Not wanting to just make sure that it's acknowledged by everyone that no one in crisis is waiting 60 days. This is a different level of services. And again, when we accumulate all of this, sometimes that gets confusing. So am I correct there?
Yes, that is correct.
All right, Commissioner Wolf.
I just was going to ask, you said, around September 1st, there's a lot of activity. Is that unique to this year, or is that?
That's a great question. So we've only been here about a year and a half, so it's really hard to compare data. We do have data from last year, and yes, we are busier than last year at this time, but I don't have a lot to compare to before then with this specific.
I thought it would be around Christmas.
We'll get busy then too, I'm sure.
So what kind of, on that time, what kind of groups are people call in for help?
Honestly, most people either call themselves to the crisis line or a family member's calling for them. That's where we get most of our calls from. Of course, we get them from law enforcement and from case managers with the county, and we get referrals from hospitals, but a majority of the time it's usually the client themselves or a family member calling in.
Is it a specific age group, or is it just all over?
We see everybody. I mean, I think the youngest kiddo we've seen is 4 or 5 years old, and we've seen somebody up to, I think, close to 90 years old. So we literally see anybody who needs us. Yes.
Thank you.
Yeah, thank you. Yeah, Neil, you started the presentation and I didn't catch it, so I just wanted to ask it again. It was bed days that it was 1,100 and now it's 1,900. What is that specifically? Again, just because I missed the details of that.
Sure, those are bed days, so that is per night per person who is staying in a bed for intensive residential treatment services. So those services will be able to be met when our new Urts and Crisis facility opens up locally. Right now, people are traveling across the state, sometimes to other states, to get access to those beds. So I think what we are finding is that it's challenging to find an opening. And so I was actually surprised to see that number jump so high. Because people are waiting and they're needing to travel for beds. But yes, it's moved from 1,100 bed days in 2018 to over 1,900
For Scott County residents.
For Scott County residents.
And this is the one that primarily, I don't know if that's a safe assumption, primarily Anoka, but I know we have to go here, there, everywhere, but is that kind of the,
So
what I associate with that?
it could be a step down or a step down from Anoka. So typically if people are exiting Anoka, they need a place to stabilize and to get supports in the community when they're ready for that. And so they could be moving down from Anoka. It could be that someone potentially might be a candidate for Anoka, but they're getting their needs met in the meantime, or somebody that we're intentionally trying to provide a service to prevent them from ending up in an institution like Anoka.
And so this is the group that would be, you use the word stabilize, and isn't, again, just clarification here, that the state is responsible for some period of time, and then when they, in their infinite wisdom, deem them stable, then it comes back to the county? Is that?
Yes, so with the Anoka Regional Treatment Facility, the state essentially covers those payments while someone is meeting criteria. When they are determined by the state to not meet that criteria, that is when the county starts receiving bills to pay for that service, which can be around $1,400 a day.
And that's when we're scrambling, there's no option, so
Correct.
they stay where they're at, and county's on the hook, and that's where the IRTs in our guaranteed bed, as I'm looking down at the guild, I keep hearing guaranteed bed for Scott County, which will be awesome. So I just wanted to clarify that. And one other, if I may, Madam Chair. Sheriff, with that Vitals app, I mean, when that first rolled out, I mean, that sounds awesome. And so now it's getting the public to gravitate to that. Is that kind of the best in class or the most widely known, or like, are there other services like that out there?
I believe that's the only one that does that specific.
And where I'm going with it is, you know, I think Chris asked, are the cities jumping on, like, so that we're not all, oh, you use this service, oh, we didn't get a read because we were using, so it's basically the only one currently. And how, with the training, how do you feel the deputies with the rollout are feeling pretty safe with that?
Yeah.
It's a great tool.
Very simple. So basically you do nothing besides initially log up, get this app going, and then it just alerts you, and when the person gets out of that 80-foot zone, the information just falls off. So it's one of those things, you just get a notification. And then we have test beacons that we take to roll call and bring on the office too periodically to verify that it's working. Right. So it'll pop up. And
I mean, that's that seems like this day and age an awesome tool. Cost for end users. So if I'm a client or out in the public, I have to do what?
So they just changed their business model slightly here this month. We found out before that they were giving one beacon free to the clients in the community. Now they let you do the app for free. So if you have a smartphone, the app's free, but any hardware, any beacons are, I believe it's $20 a beacon, something like that, that they'll sell you in their products. So we just learned about that last week.
But $20 to get it, not $20 a month or anything like that, right? Great.
Thank you.
Commissioner Beard, any comments?
Madam Chair, I had two comments. One regarded the discussion around the Vitals app. We just had that. The other regarded the 30 to 60 day gap between calling for help and actually getting help as it appeared from the discussion. You clarified that.
I read your mind
there. There you go. That's frightening, actually, Madam Chair.
Commissioner Howard.
Yeah, I'm looking at something here, and probably you'll know about me, that if we have a topic, I'm sometimes Googling stuff related to the topic, and I did that here. I'm looking at a conference, 19th Annual Conference on Mental Health, put on by the Jewish community. in Minneapolis. It's called Creating Health. And what I'm thinking about is, are we speaking broadly and comprehensively enough in our community to health-related issues? What goes into health? How can people manage their health, have a healthy life? What issues could we be speaking to? I mean, depression, anxiety, addiction. I mean, I know there's the aspect of mental health and managing mental health, and there's the issue of mental illness, and sometimes I would guess a mismanaged mental health could lead to mental illness, but other times it's just straight, obviously a biological disease like heart disease or kidney disease, or But I guess I'm wondering, what can we do in our community? I always hear the faith community saying, how can we speak to issues in our community? What can we do? How could we partner together on issues? Others are Fish. Fish is always asking, how can we come together and speak to critical issues in the community? I guess I'm wondering, do we need a mental health conference here with multiple topics, and if you need, people to go to this, and if you need more, like Terry, you've spoken on issues related to suicide and suicide prevention, that would obviously be a workshop or topic in a potential conference. I mean, are we doing that, or is there enough of that already in the community? That's my question. I mean, how can we speak to the whole community on mental health that would benefit us on the back end?
Well, I think for us in social services, I think we really focus on the service component of that. But I think certainly a number of our teams utilize those trainings that are out there to help educate us on that work. So do we need to host something locally? I think that might be interesting to try to engage some of our community members. And certainly any opportunity that we have to spread awareness, I think, is helpful. But I think we do have quite a bit of trainings available to us, especially with having the mental health center here. It has been incredibly helpful for our staff in not only our mental health units, but across HHS when we're seeing a need for that. I think you speak to the very clear tie between just overall health and mental health. I mean, I think that is something that we are always exploring new ways to engage our community and to help support our staff in that. So I think that's an interesting idea.
I'm all aboard.
Right, well, we'll maybe explore that.
Well, I know we're about out of time for this matter, but I want to thank all of you, not just for your presentation today, but for the solid work over the last years in making progress on this issue. I think so much of what was talked about today illustrates our fine line between what is the role of specifically county government in this huge issue. How can we help without impeding people's private decision-making rights and dignity and ability to make their own decisions? We've wrestled with those areas, and I feel like we've really set up structures that promote and look for those things. I'm excited about kind of the work going forward, because I see that some of that's maybe even a little bit easier. Some of the work we have to do has to do with awareness and communication of the different parts we have here. Just off the top of my head, I'm like, we really should be marketing or promoting the mobile health crisis team and our mental health centers, crisis, they can meet within 4 hours too, kind of together. Like, here's two options, and nobody cares which one. It's like, can you get in there? You want to go during the day and you don't want somebody to come to your house? You're going to pick this one. You need somebody now, you're going to pick this one. It should be almost marketed together and making sure that we're taking out any artificial lines that we don't need. So I'm really excited to see what can happen there. Excited to see, I think we're really ready now and poised to bring in more nonprofits, more private agencies, and help them help us, help them fill some of these gaps. So thank you, congratulations, and we're looking forward to hearing more in the years to come. So